Okay, so let's talk compensation. The body wants balance, and it's going to do whatever it can to compensate, and we have a few core homeostatic mechanisms built in. Renal regulation is one of the big ones. Porth spends a significant amount of time talking about the hypothalamic and pituitary, and then also we have adrenal cortical regulation as well. So let's start with the kidney. So I had mentioned the kidney earlier in that it really is the primary organ for regulating fluid and electrolyte balance, and it does that by adjusting urine volume, and it really will determine whether or not it's going to reabsorb and or excrete water and or electrolytes. And those renal tubules are where quite a bit of action is occurring, especially with aldosterone and then ADH, which is your anti-diuretic hormone. So take a look at this little chart. I think it's a good one. So when we have decreased renal perfusion, often when we have decreased plasma volume, so again, that intravascular space is dry, remember that is extracellular, that will trigger an increase in renin secretion, which will then trigger an increase in plasma angiotensin II. You will learn during cardiac that angiotensin II is a potent vasoconstrictor. The other things that are coming into play here are that in light of an increased serum potassium or a decreased serum sodium, neither of which is appropriate for our body, and also stress, physical, and trauma are going to increase ACTH. All of those things together are all going to impact on the secretion of aldosterone and increase that. And that increase ultimately leads to hanging on to sodium. And where sodium goes, water follows. So when we hang on to that sodium, so we started with decreased renal perfusion, decreased plasma volume. Our ultimate goal is to hold on to some volume, and we're going to do that by triggering this algorithm, and then we're going to have sodium reabsorption. Where sodium goes, water follows, and then the opposite inverse relationship is with potassium, so we're going to see an increase in the potassium secretion. So what does the kidney really do? It regulates that extracellular volume and osmolality, and again, that selective retention and excretion. It does the exact same thing with electrolytes, particularly excreting any unneeded substances. It also works on pH, and we're going to talk about that when we talk about ABGs and when we talk about acid-base balance, and it really works on that specifically through retention of hydrogen ions, and then it also excretes metabolic waste and toxic substances. So don't forget the little things about the kidney. You know, you've probably heard of the nephron, which is the workhorse of the kidney, filters 120 milliliters per minute. You have to remember that renal function is the most important regulator in fluid balance, and normally we're looking at the kidneys filtering, you ready for this, 180 liters of plasma every day, but we're only putting out 1 to 2 liters. That's quite a bit of decision making your kidneys are making. You know, it's really reabsorbing 178 liters, which is 30 oil changes for a car. I mean, when you put that in perspective, that's pretty amazing as far as I'm concerned. And really, that homeostasis, we're going to control that through Bowman's capsule, length of tubules. All of those things related to kidney function really come into play, all pretty significant. So adrenal cortical regulation is the other one. Renin, angiotensin, aldosterone system. I'm going to hope you've heard of RAAS. It's one of our primary systems we use, and we'll talk about that in just one second. The other one is your glucocorticoids, i.e. cortisol. That's probably why we call it cortisol. And then you have aldosterone. I'm not even going to attempt the other. So you'll see that cortisol is primarily releases amino acids from the muscle, and it also mobilizes fatty acid from your fat stores, and it really has to do with your ability of your skeletal muscles to really maintain contractions and not get fatigued. And then aldosterone really works to maintain normal blood volume. It really regulates sodium and water retention, and it also increases urinary excretion of potassium and hydrogen ions, and we had mentioned that in the previous slide. So let's spend just a moment on the RAAS system. Now, this is really a kidney system, but it also involves the entire body. So look all the way over to the left. You'll see liver, you'll see kidney, you'll see lungs, and then you'll see adrenal cortex. It really is a fabulous system. One of its primary functions is really cardiac. And so it really works on maintaining blood pressure. And if you look in the bottom right, because if we have low volume, we tend to have low blood pressure. When we have vasodilation, our blood pressure drops. And so a lot of what is occurring here is related to blood pressure and cardiac, but it's so intricately enmeshed in what's going on with the kidney function, and the kidneys are really running this show. So what happens here is that the kidneys release renin, and that is released in response to a decreased renal perfusion. So if the kidneys are getting decreased blood flow and or sense hypovolemia, they will release renin. That will then lead to production of angiotensin. And angiotensin 2 stimulates the adrenal glands to release aldosterone, and in and of itself, it's kind of a vasoconstrictor. And so what will happen is that aldosterone will then work to help the kidneys retain sodium and water. And remember, where sodium goes, water follows. So we're going to increase those fluid volumes and increase those sodium levels. You know, the other thing that's happening, if you look at that conversion of angiotensin 1 to 2, so in addition to that kind of fluid part with sodium in particular, renin also activates angiotensin 1 and changes it to angiotensin 2. And that also stimulates thirst and stimulates the release of aldosterone in the adrenal cortex, which leads to vasoconstriction, hence increasing your arterial pressures. So that aldosterone can also act as an excellent volume regulator. And that's kind of the base overview of the RAAS system. This is a really good visual. I recommend you spend a little bit of time on this one. And then the last one is the hypothalamic pituitary regulation. So we have these osmoreceptors in the hypothalamus, and they actually sense fluid deficit or increase. And when they sense especially deficit, they'll stimulate thirst, and they'll also trigger the release of ADH, which is the anti-diuretic hormone, which means we don't have release of urine. So it will stimulate ADH release from the pituitary, which therefore increases free water and decreases, when we increase the water volume, we decrease the concentration, the osmolarity. So it increases the water and decreases the plasma osmolarity. And so that oral intake is controlled by the thirst center in the hypothalamus, and it's deactivated by decreased serum sodium, so decreased serum osmolality, and activated by increased serum sodium when we have increased serum osmolality. So water excretion is controlled by ADH, which makes the renal tubules and collecting ducts more permeable to water. And so when that's more permeable to water, it makes the water able to easier return to the systemic circulation. So it's a fairly interesting process, because what happens is that hypothalamus senses the decreased blood volume, and it's secreted in response to decreased perfusion and changes in osmolality. And then that increased serum osmolality signals the pituitary gland, and that pituitary gland secretes ADH into the bloodstream. That ADH acts on the distal tubules, increasing permeability to water, increasing water absorption, increasing arterial pressure, increasing perfusion, and the kidneys retain water, boosts blood volume, decreases osmolality, and then ADH secretion is ultimately inhibited because we no longer need that anti-diuretic hormone. So it's kind of an interesting thing. So thirst basically compels you to drink water, and we all know, when we're dry, we are thirsty. But I bet you didn't realize the complexity of that system going on behind the scenes. It is a pretty interesting system. So when we think about thirst and ADH, another word for ADH and an exogenous drug that we use is actually called vasopressin. So you may see vasopressin occasionally in relation to ADH, that anti-diuretic hormone. And ADH is a small peptide. It's really only like 9 amino acids in length, and it's synthesized by cells in the supra, which means above, supraoptic and paraventricular nuclei of the hypothalamus, and then transported along the neural pathway, which is called the hypothalamic hypophyseal tract, to the posterior pituitary gland where it is stored. So what happens is when all these things are triggered, we actually have stimulation that occurs by nerve impulses. Those nerve impulses travel down the hypothalamic hypophyseal tract to the posterior pituitary gland, causing that stored ADH to be released into the circulation. And that's the basic process of what's going on. But, we have to remember that our brain is really triggering all of these things in relation to basic thirst, and that's pretty interesting if you ask me. So there's a few other things we need to keep in mind. So the antidiuretic hormone, ADH, vasopressin is another name for it, really controls the reabsorption of water by the kidney. So we do have two anomalies. We have two conditions where the antidiuretic hormones are actually altered, and we're going to talk very quickly about these two. So diabetes insipidus, which is typically called DI, we have insufficient levels of ADH. So if you have insufficient levels of ADH, you are just going to release and release and release and release water. So you have production of large volumes of dilute urine. You don't have enough for that anti-diuretic hormone. And this can be neurogenic, which we consider central. So you'll see central with like brain lesions, but you'll also see it in some inflammatory or autoimmune. The difficulty with that central is that we tend to have 80% damage, 80% loss of nephron function before we see this poly, which means much, so polyuria. Another cause can be nephrogenic, and nephro is kidney. So it can actually be that the renal tubules are insensitive to ADH. So that can be congenital, or it can be related to lots of different things, electrolyte disorders, some toxicities, pyelonephritis, inflammation of the kidney. So we have a few different causes of this, but the ultimate signs and symptoms are very similar. We have polyuria. Poly means a lot, so we'll have greater than 300 milliliters per hour, which, if you think about it, we're only supposed to have about 2 liters a day. So if you think about 2 liters a day greater than 300 an hour, that means every 8 hours we're putting out what we should be putting out in 24. Significant. We do have thirst associated with this, and again, that urine is dilute, 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 so the specific gravity is low, 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 and then that serum sodium can vary a little bit. It can be high if we're losing water only and not sodium, or it can be right around that 150 range, and that's maybe where we'll see that. So what are we going to do about this? We can actually administer vasopressin, which remember I said is another way we refer to ADH, but it's an exogenous form called pitressin. And we can administer that antidiuretic hormone directly, but we do need to watch because it does have pretty profound vasoconstrictive, so it will increase blood pressure, and sometimes we use it specifically for that purpose. The other thing to keep in mind that's very commonly used is called DDAVP, desmopressin acetate, but most people refer to it as DDAVP. It can be given orally, IV, sub-Q, nasal spray, but with these drugs, in particular the desmopressin, the DDAVP, we do increase or decrease doses, and that's what titrate means, based on urine output and also the systemic vascular resistance. What's our tone in our arteries and vessels? What is our return? What is our afterload, if you will? And we also need to monitor specific gravity in relation to that, in specific, the osmolality. We've also found some success, but although it is a little partial with thiazide diuretic use, which seems a little contrary, but what thiazide diuretics do is they increase sodium excretion by the kidneys. And what we see when we have this sodium movement is that we have volume contraction in the extracellular space, which decreases our glomerular filtration. And what we're finding is that it actually has an inverse effect and increases sodium and water reabsorption in patients who are experiencing DI. The opposite of DI is something we refer to as SIADH, so Syndrome of Inappropriate Antidiuretic Hormone, SIADH. This is the exact opposite. This is that there is failure of the negative feedback system that regulates the release and inhibition of ADH. So what happens is you have excessive release of ADH from the pituitary gland, which means we hang on to everything because we have increased permeability of the renal distal tubule and collecting duct, and we hang on to all of our water. So that is the exact opposite of what's going on with DI. And so what does this patient look like? This patient is massively fluid overloaded. And so all of their lab values have that dilutional effect we talked about with hypovolemia. So their serum sodium is typically low. Their serum osmolality is typically low. They're so dilute. They have so much fluid on board. Their specific gravity tends to be more concentrated because they're not dumping any water with their urine. But that specific gravity can vary a little bit. The key there is that the specific gravity must be higher than the serum osmolality. And that's how we look at that comparison. So what do? We have to treat the underlying cause, but you have to keep in mind SIADH can unfortunately be chronic, and so we may manage the patient otherwise. And a couple of ways we can treat is with a fluid restriction, and that would be 800 to 1,000 milliliters a day. And we may also give diuretics in this instance as well, just to offload some of that fluid. We're definitely going to monitor that sodium and treat as needed. We're going to talk about 3% sodium chloride in the next content area, so we'll swing back to SIADH, and I want you to remember that we use 3% in SIADH when we talk about that.